Alright guys, in this video I'm quickly going to discuss the 7 MCQs which were there in my Telegram quiz, and the topics were retinopathy of prematurity, retinoblastoma and age-related macular degeneration. So first question was, a child aged 1.5 year is brought by parents with leukocoria flexor wintersteiner rosettes. The most probable diagnosis is, now the two hints which is given in the question is self-explanatory. The most common age of presentation of retinoblastoma is 1.5 years, that means 18 months, and typically pathological diagnostic finding flexor wintersteiner rosettes, it point towards retinoblastoma. Now let's eliminate the option one by one. So retinopathy of prematurity, of course the age of presentation is early, so that cannot be the answer. Leukocoria will be present but flexor wintersteiner rosettes will be absent. Congenital cataract, leukocoria may be present, it may even present at the age of 1.5 years, yes, pediatric cataract, right? But flexor wintersteiner rosettes will be absent. Congenital glaucoma, there will not be leukocoria, there will not be flexor wintersteiner rosettes. Age, yes, age syncs with the presentation of congenital glaucoma, but again we have to match one option which goes in sync with all the 3 points. But as I have told you, two telltale features: age of presentation 18 months. In this question, flexor wintersteiner rosettes point towards typically retinoblastoma. But as I always say, always try to eliminate the options 1, 1, 1 and reach up to the fourth final answer. Alright, treatment of choice in wet ARMD. You already know ARMD is age-related macular degeneration. There is dry ARMD, there is wet ARMD. So in dry ARMD, there is presence of drusen. Drusen is nothing but the metabolic waste products and lipofuscin which is deposited between the retinal pigment epithelium and Bruch membrane, yes. While in wet ARMD, wet means gila, wet means wet, of course, है ना? So if there is neovascularization, because in neovascularization there will be blood has plasma which is water, so wet is gila. So in wet ARMD there is neovascularization, so they have asked about wet ARMD, of course, which has neovascularization. What will be the treatment? So first, intravitreal dexamethasone, no. Dexamethasone is steroid, no help. Then PDT, yes, PDT can be done. PDT is photodynamic therapy, in which we inject a dye and then we expose the eye with diode laser. So this dye which we had injected, we are going to do it a little later. There was another question. So this dye will cause photosensitization of the vessels, and on exposure to the diode laser, there will be sclerosis of the vessels. Which vessels? The new vessels, neovascular membrane which is formed, yes. But they have asked about treatment of choice. So PDT, of course it can be done, but it is not the treatment of choice. Antioxidants are given, yes, but they are again not the treatment of choice. They are mainstay of the treatment in dry ARMD. Answer is intravitreal ranibizumab, which is your anti-VEGF. Because I told you na, we are talking of wet ARMD, which means blood. So we need to regress neovascularization. So for that we will give anti-VEGF. Intravitreal anti-VEGF is given. Okay, so that is the answer. Yes. Okay, now Rush syndrome. So here we are talking of retinopathy of prematurity. So Rush syndrome is a simple term which is when there is presence of dilated and tortuous vessels, yes. But what are the other three options? So basically we are talking of threshold ROP. Now what is threshold ROP? Threshold ROP is a severe form of retinopathy of prematurity in which there are 4 criteria. First is that there should be zone 1 involvement. There will be zone 1 or zone 2 involvement of the disease. So zone 1 in the central, zone 2 is periphery to the central, and zone 3 is the most peripheral zone. So the more will go towards the periphery, the less dangerous it will be. So zone 1 or zone 2 involvement, that is the first criteria of threshold ROP. Threshold ROP. Or if the disease is stage 3 onwards, that means stage 3, stage 4 and stage 5. So that is the second criteria of threshold ROP. Third, if there is 5 consecutive clock hour involvement of the retina. If there is 8 non-consecutive clock hour of the retina involvement, then also you consider it under threshold ROP. I hope it is clear. And fourth is Rush syndrome, which is dilated and tortuous vessel. So Rush syndrome is in sync with extreme form of disease. Why it is extreme form of disease? Because more is the neovascularization, more is dilated and tortuous vessels, because the new vessels which are formed, they are dilated and tortuous. So dilated and tortuous is synonymous to neovascularization. So Rush syndrome is a single term, but I have just told you the criteria of threshold retinopathy of prematurity. Now, which of the following is not a risk factor for ARMD? Simple, as I always say in my class: daru, sutta, chicken. Yes, so there is alcohol, which is a risk factor, smoking, which is a risk factor, and not vegetarian diet, it is actually non-vegetarian diet. And white race, it is also common in white race. So this is a simple clear-cut question based on the etiology of ARMD. Now, most common feature in retinoblastoma, you know there are battery of features. Most common, which is seen nearly in 60-65% of the patients, is leukocoria. But second most common is your squint. There is pseudo hypopyon. Now you will say, sir, hypopyon is pus in the anterior chamber. What is pseudo hypopyon? My dear friends, it is tumor cells in the anterior chamber. Tumor cells in anterior chamber. And of course, there can be proptosis, but the most common remains leukocoria. Now coming over to stage 3 in ROP. So there is a staging in retinopathy of prematurity. So there is stage 1, 2, 3, 4 and 5. So stage 1 is when there is a demarcation between the vascular retina and avascular retina. Now, you know, when there is avascular retina, this avascular retina starts producing VEGF, which will induce neovascularization. So after stage 1, there is stage 2, in which there is ridge formation. Suppose, see, this is the retina and there is, so this is the demarcation line. This is avascular retina. This is your vascular retina. So first is your demarcation line. First is demarcation line. Second is there will be a ridge formation. Ridge, you understand? Like we have got a speed breaker on the road now. So there will be ridge formation. Yes. And stage 3 is your fibrovascular proliferation, because by stage 3 there is so much production of VEGF that it will induce neovascularization. So there will be a lot of neovascularization which will be forming. But if there is neovascularization, there is formation of neovascular membrane, you know that it can easily pull the retina. So stage 4, if I talk about stage 4, it is divided into 2, 4A and 4B. Stage 4A is when there is subtotal retinal detachment, but it does not involve retina. Not retina, it does not involve macula. And stage 4B is when it involves macula. And stage 5 is when there is total retinal detachment. So if you know the staging, you can easily tell that the answer is your fibrovascular proliferation. Okay. Which dye is used in PDT? PDT is your photodynamic therapy. So in photodynamic therapy, we inject a dye which is verteporfin, and after a while, when the dye appears in choroidal circulation, because there is choroidal neovascular membrane which is present in ARMD, so this dye will also enter in the neovascular membrane, and this dye has the tendency to cause photosensitization. So when you will expose the vessel containing this dye to diode laser, there will be sclerosis. So that is the technique by which you can treat the choroidal neovascular membrane in ARMD. Now I want to give you one important point. Fluorescein dye and indocyanine green, they are used in the retinal imaging. Fluorescein dye is used in the imaging of retinal blood vessels, while indocyanine green is used in the imaging of choroidal blood vessels. Now, the important point which I want to tell here is that fluorescein dye is relatively less protein bound and indocyanine green is more protein bound. Now, fluorescein dye has the tendency to absorb the light of short wavelength and emit the light of long wavelength. So it is good for retinal circulation. But indocyanine green has the tendency to absorb the light in near infrared spectrum. Now you will say, sir, why we cannot use fluorescein to even assess the choroidal vasculature? Because there is one membrane which is retinal pigment epithelium, which has the tendency to absorb the light of high frequency. So we need a dye which actually utilizes the spectrum which is not used by any layer of retina in between. So for choroidal vasculature, we prefer indocyanine green, not fluorescein dye.